Good afternoon. It's a real pleasure to be here for this symposium called Align for the Future with Myval Valve series from randomized trial to everyday clinical practice. I'm here with Andreas Bombach, which is the speaker person. I am the anchor person, and he will introduce the discussion. So we are going to know more about the pivotal landmark randomized control trial and its relevance in clinical practice. After that, we will learn about the novel Myval Octapro. That's really a novelty, the key features, the procedural impact, and potential clinical benefit. Then to know the Octalign technique, which is every day a little bit more important, which enable predictable and precise commissural and coronary alignment, thus preserving coronary access for a later second valve redo. And finally, to understand the technique of precise sizing, positioning, and deployment of the Myval series in real-world clinical scenario. Andreas, do you want to introduce the member of the panel?
Yes, we have a fantastic panel here, starting on the left, my left, Christian Hengstenberg, Caterina Gandolfo, and on my right, Gunasekaran Sengo Tuvelu. Now I know how to say that, Sengo. And Marco De Carlo. And I'll introduce you. You give the first talk with new data on the landmark trial.
Okay, we are going to review the landmark trial, and this is my potential conflict of interest. And I can tell you that the data that I'm going to present on behalf of Niels van Rooij, Ignacio Amat Santos, Martin Udek, and Maya Bunks, the four top recruiter in this trial, and of course with Andreas Bombach, these data that I'm going to present is in Eurointervention since yesterday. So you know the landmark, it's a prospective, randomized, multi-center, open-label, non-inferiority trial. What I'm going to present this time is the individual comparison of Myval with Sapien and Myval with Evolute. As you remember, in Paris, we will putting together these two valves and called the contemporary valve. We are going to talk about the primary composite endpoint according to VARC-3 at 30 days. This is listed on the next slide. All-cause mortality, all stroke, bleeding VARC type 3 and 4, acute kidney injury stage 2, 3, and 4, major vascular complication, moderate of severe prosthetic valve regurgitation, and new permanent pacemaker. Now, what is important is that what we published in the Lancet was a statistical scheme of two Myval versus the combined Evolute and Sapien, so a 2-to-1 randomization, and that had a power of 93%. Today we are going to have in a statistical scheme two Myval versus one Evolute versus one Sapien, and the statistical power that was planned that way is still 80%. I have to remind you that in the Myval series, we have 9 nominal size. You see the annulus area and the dimension. I have to tell you that the extra large 30.5 and 32 are not randomized, but are collected in a registry. Sapien 3 and Ultra, we have 4 normal size, 20, 23, 26, 29. And the Evolute R, Pro, Pro Plus, or Flex, we have also 4 nominal size, 23, 26, 29, and 34. I have to tell you that although the 23 was on the shelf, it was not used by the investigator. Quickly, the baseline characteristic by randomized design, they are equally distributed in the 3 valve. We look here at the age, the gender, the body mass index, the 6-minute walk test, the SF12, the STS-RIC score. On average, the median was 3%, and 3/4 of the patient was less than 4. In terms of medical condition and medical history of previous condition, I have been ranking by prevalence. You could see hypertension, glomerular filtration less than 60, diabetes, atrial fibrillation of Flutter in about 1/4 of the patient, glomerular filtration less than 30 ml, and COPD are the key point, but you see also on the slide previous CABG, previous stroke, and previous pacemaker. Echocardiography, classically a 40 millimeter of mercury for the transcenotic gradient, valve area 0.7 in the 3 group, and the multi-slide CT scan finding 470 millimeter square around in the 3 group, and around one third of the patient with a small aortic annulus less than 430. Bicuspid valve between 6 and 7.8%. Now, let's start by the Myval versus Evolute. This is the dashed line for the zero difference. And as you could see, the Myval has minus 5.3% event when compared to the Evolute. So basically, with the 95% confidence interval of this distribution, we reach the non-inferiority 0.0001. The actual numbers are for the Myval 24.7 and for the Evolute 30%. And we are, as you have seen, below the margin of non-inferiority. If you look at the component of this composite endpoint, they are all non-statistically significant. I put in green where the Myval has a small numerical advantage, but no statistical difference. Now, if we go to the Myval versus Sapien, you see again the dashed line of zero difference. The difference now is minimal, 0.6%. I'm pleased to see that because yesterday we see compare TAVI at 1 year with 0.9%. So it seemed very similar, at least at 30 days. And you could see that all the components of the primary endpoint, the composite endpoint, are non-statistically different. So the actual number is 24.7% in the Myval and 24.1% in the Sapien. So this is the pre-procedural aortic annulus area and the post-procedural effective orifice area, EOA. What you see is that the green dots for the Myval are proportional to the number of patients in each categories, and superimposed in the slide, you have the nominal size. If we go to the Sapien, you could see that with the exception of the 20 millimeter, systematically for the 23, 26, and 29, the Myval has a larger effective orifice area than the Sapien, with statistical value here tabulated. If we look now at the Evolute, we see that for the 26, which is compared with the 29 of Evolute, and the 29 of Myval compared with the 34 of Evolute, there is no difference, statistical difference. The only difference is between the 26 Evolute and the 23 Myval, and that's a significant value that you see there. Now, this is the reverse. That's the pressure gradient. I don't have to comment that too much, but as you could see, the Myval for the 23 and 26 has a lower pressure gradient than the Sapien, but these Myval versus Evolute, Evolute with a nominal size which is large, is all three significant. Now let's do what I call a smart analysis, you know, the trial, small annuli randomized trial. And let's look only to the aortic annulus less than 4.30 millimeter square. On the right-hand side, you have the annulus area versus the post-procedural AOA, and you could see the green point of the Myval are higher than the red point of the Sapien. So there is a statistical difference with a larger AOA for the Myval. When you look at the Myval versus the Evolute, you see clearly that the blue point are separate from the green point. In other words, the effective orifice area of evolute is significantly large. But in the small annulus less than 430 millimeters square, the rate of prosthetic valve regurgitation is significantly higher in evolute, 11.9%, than in Myval, and I showed that there was no difference in prosthetic valve regurgitation between Myval and Sapien. So when compared to Myval nominal size 20, 21.5, 23, 24.5, there is apparently a disadvantage to oversize all the small annulus less than 430 with a 26 nominal size evolute. And a few years ago, in 2017, we have shown that when you do that, you end up with eccentric expansion, elliptical area, and that elliptical area can create what we call the pin-wheeling effect and can be the reason why we see more regurgitation in the evolute. I'm finishing by a suggestion of Axel Link, one of the investigators in the trial. He said, look, if we have an octacore with a diameter of 21.5, and we look at the native aortic annulus, in this case, 351 millimeters square, and you can derive the diameter from the area or from the perimeter, 20.1, 20.4, but the ratio is close to 1. So it is interesting that if you see the histogram of what we call the fitting index for Myval, you see in green is the Myval, in red is the Sapien, and the overlap is brown. Now, to make the things a little bit more simple and visual, here is the density curve of the fitting index for Myval and Sapien. And you could see that between X and Y, they have the same fitting, but there is two regions we fall outside this fitting. So when the Myval and Sapien are equally fitting the aortic annulus between X and Y, there is no difference in pacemaker, 15 versus 14.1. When the Sapien fitting index is outside the fitting boundaries of Myval, there is a numerical difference, 15.2 and 21.1. We are pulling the data with compare TAVI to see if this information is confirmed. But today we can say that the non-inferiority of Myval versus Sapien and evolute in individual comparison was confirmed. When the EOA of conventional size 20, 23, 26, and 29 are compared, Myval series of even 24 to 20 millimeter or significantly large EOA, that Sapien series and similar EOA for the evolute 26, 29. In patients with small annulus below 430, EOA and mean pressure gradient of evolute without the use of the 23 millimeter, not used by the investigator, is significantly better than Myval and Sapien at the cost of a significantly higher rate of PVR. When the fitting index of Myval and Sapien were comparable, their rate of PPI were similar. When the fitting index were not comparable, the rate of PPI in Myval was numerically lower than in Sapien. Follow-up for the next 10 years and pooling of the landmark data with the data of the trial compare TAVI will unravel where the document EOA and Myval of the Myval will have a beneficial impact on the long-term patient prognosis and valve durability. Thank you very much.
Thank you very much. I think that was the most comprehensive evaluation of the landmark recent data. Fantastic job. Now we move swiftly on. We might have some time for questions at the very end. For that, please use the app and the questions will appear here in front of me and I will then ask them. Next up is Andreas Holzhammer, who will tell us a bit about the features of the Myval THV series.
Thanks for your kind introduction. Okay, I was asked to speak about the Myval from a clinical perspective, what the benefits of the system are. So I thought, what does it make special? And I think the first thing, of course, is the valve. I don't want to go too much into detail here because we will hear this very detailed later on for the latest generation. But the really unique, outstanding point, and this is how many people of us got in contact with this company also is this very large sizing chart. We briefly heard in the previous talk that there's an XL cohort which was not randomized. Of course it was not randomized because there was no other therapy for these very large sizes available. And when you do TAVI, you will find these patients in a certain number, maybe 2-3%, but we could not treat those. And very often, at least in my clinical experience, these are the worst. Sick patients, aortic insufficiency. You will need these very large devices also to treat pulmonary patients, which are often very sick. So that definitely was a huge contribution to our portfolio, and basically the reason why we started with the whole program with Navitor, with the Myval devices. So we did an analysis on this, and this is very varying from country to country, at least in the sales numbers of the company. And there is not really much data about basic anatomy. We always watch at our cohorts as treated, but we found that we have about 3% of our population of aortic stenosis, which are too large for the commonly available devices. And that was, in our analysis, the most frequent reason of anatomic contraindications to TAVI. And we could, almost in all patients, overcome this with an on-label indication using the 32 Myval and Octacor devices. Here's our very first case we did. Standard TAVI patient. The implantation itself is not very different from a regular anatomy. So it was pretty straightforward here. We implanted quite carefully, slowly. Did the implantation and ended up in a very satisfying result in this 82-year-old case. Definitely something we use in our routine now. The other thing which makes this table so large are the intermediate sizes, and we heard very nicely about the potential benefits which need to be assessed in further data, which will be quite hard to prove. But to keep it simple, when you have a device in the size that you prepared for, the more tailored will make sense. The leaflets are cut to the size for this kind of expansion, and that is how we all do our sizing. We don't go for 26 for male, 23 for female, as Christian Hengstenberg knows we did in very former times. But we try to tailor this, and having more devices available might make this tailoring more precise, and that is used in common practice. But there is a cohort of patients where this is even more crucial, at least in my opinion. And this is what we will face in future more and more, and this is our valve-in-valve procedures. Let's take a look at this particular case. It was a degenerated accurate device, first generation, with pure insufficiency. The stent was expanded to 21 millimeters. So what do we implant here? Pretty small anatomy, no surgical candidate at all. We will face these patients more and more now. And there's some bench testing done, implanting 23 device, which clearly shows we cannot expand this device. And we nicely heard about pinwheeling and these issues. And this will be most relevant in these valve-in-valve anatomies where we have no chance to adapt the anatomy to our valve-free implant and where we need these tailored approaches. And having this bench testing data with micro-CT of actual valve-in-valve implantations on the bench, seeing that we can expand it up to 21.5, it seemed obvious to us that we need to treat that patient with a 21.5 octacore to avoid this situation here, which is the under-expansion, which is 20% of when using 23 millimeter Sapien and probably also when using 23 millimeter octacore. So we did this first valve-in-valve patient was really bad. This is rapid overpacing. The patient is not dead. However, there was absolutely no very poor ejection fraction in that situation. We could implant the device. Patient recovered immediately, fortunately, and we had a perfect result with absolutely nice hemodynamics and a good outcome. So again, here the intermediate, really a clinical benefit where a definite need is met. The next important part of the system is the catheter, of course, and the catheter is different to others. The genius idea, in my opinion, is to have these two cone-shaped, company calls them stoppers, plastic cones within the balloon, which allows to simply crimp the valve on the device. And this is something we never talk about, but in my opinion, the ease of crimping to get the stuff easy trained, to have this 24 hours a day available. I can crimp it myself. This is the only device where I managed to crimp it myself. So I can use it at night as a bailout option whenever needed. So this is definitely something where a very good idea, having these stoppers adds flexibility to the hospitals and is really having a big benefit for the healthcare system, I think, to avoid more training, more complexity in this already complex field. But the main reason to have these stoppers are that we don't need any kind of pushing system. And that allows two things. One thing is to keep the catheter very slim, 12 French, and to keep it very flexible, which is something we don't very often need in TAVI, but what we need in more complex procedures where we need to get tight curves over the wire, like this tricuspid valve-in-valve procedure, alternative access, transeptal procedures. There, this very flexible catheter turns out to be quite handy and nice to use. Another aspect is the sheath, of course. The Python, is it called, sheath? You can see here a bench testing where you can do up to the 32 diameter valve. You have the same sheath with only 14 French unexpanded. So it's quite easy to introduce on the one hand side, but the other very big benefit of this device is that due to the combination of the navigator delivery system and the sheath, that you can retract everything out of the patient's anatomy in case you have any unplanned circumstances, loss of guide wire, problems to cross anatomical structures. You can simply pull it out of the patient's body and don't have the situation that you need to get rid of the valve before by implanting it somewhere. Definitely something which adds confidence. You can see here two examples here. The transeptal crossing was just not feasible, which is kind of a big problem when you have no option to retract the device. Here you simply can pull the device out. Another example here, you see how the valve is just retracted in the sheath and out of the patient's anatomy. And if you combine all these things together, you have intermediate XL sizes, you have a high flexible catheter, you have the retrievability, you have a very low stent height, which is adding options for many treatments. We have the Octalign technique that we will hear later. And of course, you can reversely crimp the device on the balloon. And if you put all this together, then I think we have a plentiness of options of where to use, in which kind of patients to use this patient, as shown here in all 4 valve positions. And the system definitely allows us to treat situations that we otherwise could not address at all. Happy that we also started, which will be the rest of the session, with the Octapro last week. And from the very limited experience, I think that this iteration does not change any of the benefits we see with the first generations and preserves these for the future. Thanks for your attention.
Yeah. Very well done and very pleasant to hear. I mean, it was so comprehensive in one nice demonstration. So the next speaker is going to talk about the Myval Octapro Pro. I hope that Mary Life will not come every year with a new model, because then we will lose track of the novelty. But that shows that the engineering in India is doing very well. Ashok.
Thank you very much. So I'm going to address the Myval Octapro and the science and design philosophy behind this. These are the potential conflicts, and we just heard and reminded ourselves around this Myval series, the uniqueness around this balloon expandable valve, and we heard the fact that this is 9 sizes ranging from 20 to 32 millimeters. But I'd also like to point out that there's a 35 millimeter Myval under clinical investigations at the moment. Directly crimped on the balloon, a transcatheter heart valve is unique, certainly. But as we understand that 19,000 implants globally across 75 countries, 4,100 patient studies with more than 90 plus publications, and nearly 50% of the sizes used in clinical practice are intermediate sizes. Across all anatomies of bicuspids, pure aortic regurgitation, valve-in-valve interventions, valve-in-ring, I think there's a consistent performance that we see in our clinical practice with the Myval transcatheter heart valve series. And of course, the landmark study showed and demonstrated non-inferiority compared to the contemporary THVs. And of course, now we have compare TAVI, a 1-year data which met the primary endpoint. Let's move on to the device philosophy. Where do we go from here? There are two aspects in the lifetime management of patients, as well as comforting the physician. First is commissural alignment, and that's an important aspect of valves. We would like to have minimal foreshortening. Less foreshortening is better to allow for predictable deployment and precise deployment across all anatomies. And I think that's the design philosophy which we're trying to achieve from Octacore to Octapro. You well realize you saw the Octacore just now. It has two rows, interlacing octagonal cell design, both at the inflow and the outflow, 50-50% divided here. And that allows for less foreshortening, and for Octacore, that's around 18 to 23%, much lower than any other balloon expandable valve. We'll move on to Myval Octapro and the design philosophy. The new Octapro has a 45%, 55% divide in the two rows of cells. The lower cell is still the octagon. That's the inflow. The outflow has now changed. The outflow has these inverted chevrons, V-shaped, for simple reversal of the crowns. This still retains the legacy of Myval, but decreases the foreshortening to 10 to 12%. And mind you, that's 12% even for the extra large size of 32 millimeters. So here's the Myval Octapro, similar to Octacore, similar design philosophy, and now, of course, these unusual inverted chevrons in the two-row cell design, again available from 20 to 32 millimeters, keeping all the features intact of the legacy of Myval. Here's its expansion in vitro, and see it again and again. There's virtually no visible shortening of the frame. 10 to 12% is not noticeable, even in vitro. And that allows for perhaps predictable and precise placement. When we have, even in Octapro, sizes which cover annular areas from 270 to 840, and add on to that is the philosophy of commissural alignment. Getting commissural alignments with the balloon expander valve is a novelty. The Octalign technique is an important concept which has actually been proven in vivo as well. Well, philosophy is simple. This, of course, is the dial, the crimper, and it's based on a clarity of thought that if you align, and that is quite clear, that if you orientate the mounting of the valve in such a manner that the commissure is aligned to the right coronary cusp, this valve, as it goes in and inverts across the aorta and implants itself, will exactly be 180 degrees opposite, which therefore means that if you aligned it to the right coronary artery, it will end up on the other cusp, and it'll end up on the other commissure, and therefore the commissures do get aligned. Well, that's the way the valve is crimped, and you will see it in the live case. Here is how it's demonstrated in a cartoon representation. And of course, the commissural coronary alignment with novel Myval Octacore technique, the Octalign technique, has been published, and it's for you to go through that. The conclusion of that are easy to practice, doesn't require additional hardware or imaging software, and the preliminary experience with Octalign technique worked efficiently with minimal malalignment in 83% patients. Come to the clinical use of Myval Octacore. Here's a patient, and I think this patient illustrates certain unique features of the valve, the ones we talk about of precise deployment. This is a tricuspid aortic stenosis, peak gradient 60 millimeters, normal ejection fraction. We have effective orifice. We have the aortic stenosis of valve area of 1.0. And that, an annular size of a 370, area-derived diameter of 21.8 is suitable for a 23 millimeter Octapro, which would be 11.8% oversized. This patient has low calcium score, and therefore a 1 ml extra is taken to create a 15% oversize of this valve. The coronary heights are normal, the STJ is normal, nothing to write home about. Octalign technique with the right coronary cusp at what we call a 032 position, which means it's aligned at not less than 90 degrees, and that's the 02. Octa-aligned technique, no predilatation of the valve crosses beautifully. But I'd like you to see this deployment, because truly that's where the feature lies. Here I'm implanting the valve. I'll start off with 85-15, but as I inject, I feel that I may end up at 0, which is my intuitive thought process for my vast experience of previous balloon expandable valves. I therefore, as you can see, push it in to be 70-30 to accommodate for a foreshortening, which has become my habit. Here is 85-15. I pushed it to 70-30. But I'd like you to see how the valve expands at 70-30. It stays exactly at the same place. It ends up at 75-25, non-discernible. There is no foreshortening that I can discern as I expand the valve. And therefore, I end up slightly deeper than what would have liked to be. What does that tell me? This is a great result, and as you'll see, but it's deeper than I thought I'd like. And while the peak-to-peak gradient, of course, there's no gradient, there's no conduction abnormalities, you can see, no PVL, no complications, the patient discharged in 24 hours. This valve represents a huge step forward from what I can see. Myval Octapro is a progressive design philosophy for predictable and precise positioning of a transcatheter valve with minimal foreshortening, and you saw that happen. I accommodated for shortening, and it didn't. We therefore have to fine-tune our traditional deployment habits. This THV can be precisely positioned at a position we would like to implant, so we no longer have to accommodate for significant foreshortening. The Octalign technique aids commissural alignment and is novel for a balloon expandable valve. And Myval Octapro is a next-gen valve, a next-gen balloon expandable valve, which may represent a step forward in achieving the goals of lifetime management of TAVI patients. Thank you.
Very good. Thank you very much, Ashok. I think it was very convincing. I mean, there is a step forward. It will be used by a new operator with some kind of very quick self-confidence about what you do. So that was excellent. Andreas, is there any question? I think the speakers are so clear that maybe there's no question.
Pretty clear, yeah. There are no clear questions. I think we can move on to the recorded case.
Okay.
Yeah?
So
Sengo has a question.
No, I was just telling about this Octapro valve. The foreshortening is less both above and below. But above it is about 10 sides, whereas below it's 8. The second row is only 8. The upper row has got 10 sides. And hence the foreshortening is much lower, almost nil in the upper portion. So particularly for a valve-in-valve procedure, or if you want to push in the valve proximally, it's so predictable. So you can just leave it like how you do a left main stent. You want the stent exactly to be placed. Just like that, we can place the proximal part of the stent in the outflow, and you can just place it exactly, and it will fall in place.
very nice complement of information. So I think we go now a little bit more in practice. We got Myval Octapro recorded case by Rao Ravinder Singh. Yeah.
So I'm going to show a live recorded case. It's a 94-year-old lady, presents with heaviness, chest heaviness, shortness of breath, giddiness, all the standard symptoms of severe aortic stenosis, fairly active. EKG, you can clearly see there's a right bundle branch block, LAHP, and first-degree heart block. Patient is post-cabbage, all patent grafts, severe aortic stenosis, high STS score of 21.6. The echo clearly shows severe AS, mean gradient of 52, and you can see a tricuspid aortic stenosis with calcification. This is a CT scan slide. Area of the annulus is 328. Area derived diameter is 20. LVOT is 20.6. Coronary height, the patient is post-cabbage. Patent graft. Sinus of Valsalva, adequate size. Now you can see there's not much of calcium at the level of annulus. Again, a small anatomy for a small patient. Nanogenarian, not much of cardiac output. The area is 328. LVOT is 299. The sinus of valve valve diameter is adequate. Sinotubular junction size is again nothing unusual, 26.7, ascending aorta 40 mm, and the coronary height was adequate. You can see a huge septal bulge there, calcified leaflet. The length of the membrane septum is 3.1 millimeter. Calcium, adequate amount of calcium on the leaflets, tricuspid valve leaflets. This was the sizing which we are trying to understand. Here's the 20 mm valve, which will be undersized, and 21.5, as pointed out by Professor, right fit, 10.7%, 23 is again too big for this, 26.6%. This is a circle method. We're trying to understand the interactions of 21.5 mm circle and a 23 mm circle. You can clearly see a 23 millimeter circle overshoots the boundaries of the annulus, too big for the annulus anatomy, and 21.5. Now, this is the slide, as you would have seen in the previous talks. When we try to position this valve as how we do the standard balloon expandables which are available to us, the valve ends up getting a deep implantation because valve just does not foreshorten. Now, you would see in this recorded case, this is how we want the valve to end, and to get this position is what you start at the same position as what you want the valve to end in. Femoral vessels, all size adequate, more than 6 mm on both sides, some tortuosity, but nothing unusual. The valve was crimped
Hello,
as per the
everyone.
Octalign.
My
So
name
we're
is
gonna
Ravinder Singh
come
Rao.
to the important point here.
This is a 6 French vein, a 6 French artery,
So,
a 7 French vein.
what I'll do, I'm just going to guide you through this because it's only a 12-minute thing. So standard ultrasound guided access was obtained. Here you can see calcification in the posterior wall of the common femoral artery. This is the calcium, and we usually use just one ProGlide reverse with protamine, and we would use a second closure device if required, if there is bleeding or any hemostasis is not achieved. And you can see very tortuous vessel. This is a normal wire. It's not a stiff wire. A normal wire is navigated up the tortuous abdominal aorta. And the pigtail catheter, again, this is again a soft wire. It's not a stiff wire. We would exchange the soft wire inside a JR catheter with a stiff wire, and the Python sheath would be placed. So these are all standard procedures, standard steps: a balloon-tipped temporary pacemaker, and pigtail catheter non-coronary cusp. So you would see this is a 3-cusp view, and then we would go to a cusp overlap view, and then we'll also do an angiogram in the cusp overlap view. And I'm going to highlight this because to do this valve, what I have noticed in my practice is you start deploying this valve in a cusp overlap view, and that actually gives us the right depth at the end of the procedure. So this is a normal wire which is being advanced. Now JR catheter goes in, and all these tortuous and calcified vessels, I mean, the standard procedure, you see under fluoroscopic vision when we advance this big stiff wire and big sheets. This is the Python sheath over a stiff wire, and you slowly, carefully advance across that tortuosity and how the infrarenal aorta straightens out. The dilator comes out, cross with the wire. The other thing which you do is you cross in a cusp overlap view. You go just anterior to the pigtail because the left and right are overlapped. The non is on the pigtail, and the opening is right anterior to the pigtail, and that's we just go ahead and cross. The rest is advance the catheter, exchange for a pigtail catheter, and then put a Safari extra small wire. To the hemodynamic assessments. And no pre-dilatation was done in this patient. Here's an Octapro valve which comes, and you can see it's tortuous, but still could be easily negotiated. Advanced. We come back to this is a cusp overlap view. You can appreciate RAO6 and caudal 34. I just want you to pay attention to the positioning of the valve, and we would just reposition our pigtail. Pigtail is advanced back to the non-coronary cusp. So this is deep, actually. You see, this is deep because that marker is below the level of the pigtail. So we want the lower end of the marker at the level of pigtail. So when you pull back, again, the valve comes on the inner curve. So you push a wire a little bit and then re-advance so that the entire system is on the outer curve or in the center of the aorta. And you can see that when we do an aortogram, you see how the lower end of the marker on the balloon is at the level of annular plane. And when you look at it, you're a little concerned. And you're concerned about that this valve might foreshorten and just fly out. But this valve just stays at the same place where it goes, where you have positioned, because it's difficult to appreciate a 10 to 12% foreshortening to the naked eyes. And you can see how the valve just did not move, and it got implanted at the same spot where we as an operator wanted to implant it. So next is standard. We would remove this thing, do hemodynamic assessment, remove the stiff wire. And again, we do an aortogram in the cusp overlap view, which actually helps us to understand the depth on the non-coronary side. And we do this for all the valves, and do one in the iliocranial view. This is the iliocranial view, where you can see the depth, and then we'll come back to the cusp overlap view. Yes. You can see, appreciate the depth, slightly little deeper on the other side, but the non-coronary cusp, it landed where we wanted. Though this patient required a pacemaker because this patient already had a trifascicular AV block up front, even before starting the procedure, the hemostasis was achieved with 1 Proglide and reversal of heparin and some manual pressure. This is the DSA. No pinching of the vessel. And we are saying thank you to everybody. So I'm going to go to the last slide. This is the echo. You can see with a 21.5 millimeter valve, the mean gradient is 3 millimeters, the peak gradient is 5.3, and normal LV systolic function. So this patient required a pacemaker post-procedure, but good hemodynamics with 21.5 millimeter valve and the right depth deployment. Thank you very much.
Very good. Excellent. We do actually have questions. Mustafa Balchi is very active asking questions, most of which you have on the way answered. In which situations should we predilate the valve?
The predilatation standard, if it's a bicuspid valve, when the operator feels it's going to be tough to cross the annulus with the valve itself, it's your call. In the earlier days, we would predilate all the valves, all the cases, but now we are not doing for all of them. Like this patient, we did not do any predilatation. But if it's a bicuspid, very horizontal, tortuous, and you think it's going to be difficult for the valve to cross, you do a predilatation.
Thank you.
Very good. And maybe I have a question for you, very simple. I saw that you advanced the pigtail when the valve was already across the aortic stenosis. Is it always going to the right cusp at that moment?
So you meant to say when the valve is across the annulus and we want to reposition? So in the cusp overlap, when you go to the RAO and cusp overlap view, you pull down the pigtail, do a counterclock, and try to keep it to the spine. It's always going to go to the non-coronary cusp.
Very good. So what we have seen today remind me a little bit what Richard Myler was said. I saw one, I did one of my mother-in-law, and I did on myself, which was the case, by the way, with the rotablator. Okay, the next speaker is Alfonso Yelazi, real-world experience with Myval Octapro. Yep.
Very much for the kind introduction. So I will share the first case we have performed with Myval Myval Octapro last week, so our experience is very limited on this device. Probably this was one of the first cases performed in Europe. So the patient is an 88 years old male with several cardiovascular risk factors, prior ischemic stroke, prostate cancer, chronic multifactorial anemia. He was admitted because of effort dyspnea, and at transthoracic echo, it was revealed a severe aortic valve stenosis with moderately depressed LVEF. Electrocardiogram showed a sinus rhythm with right bundle branch block, and STS score was 7%. The patient underwent CT scan evaluation. As you can see, the area at the level of the annulus is of 419 millimeters square. The LVOT was smaller as compared to the annulus, and there is a chunk of calcium from the NC protruding down into the LVOT. Leaflets are mildly to moderately calcified, and there are some calcification also at the level of the annulus. Again, the chunk of calcium protruding from the, extending from the NCC to the LVOT, you can appreciate its length is about 4 millimeters. So this is a situation associated with an increased risk of significant PVL, risk of permanent pacemaker implantation, and even annular rupture. STJ, ascending aorta, sinus of Valsalva diameters were relatively fine according to the annular size, while coronary height was fine for both the right and the left coronary artery. Iliofemoral axis were fine in terms of sizes on both sides, and no tortuosity were revealed at the level of the abdominal or thoracic aorta. Also, the aortic angle was around 50 degrees, so no horizontal aorta. So case recap, 88 years old male with CKD, right bundle branch block at baseline electrocardiogram, moderate LV systolic dysfunction, and severe native aortic valve stenosis with calcium protruding into the LVOT. So the idea was to choose a transcatheter heart valve which can be precisely positioned without low implantation depth into the LVOT, trying to avoid injuries, increasing the risk of permanent pacemaker implantation, rupture, and PVL. So the choice was Octapro. The features of this device have been already described before. So as you can see, 2 rows of interlacing cells. The first row is octagonal, while the other has a different shape. The skirt is internal and also external, providing a good barrier against PVL. So this is the planning, interventional access, right common femoral artery. A Landerquist wire was planned to be positioned at the level of the left ventricle. Pacing was planned from a lead into the right ventricle because of the right bundle branch block at baseline electrocardiogram. Octapro 24.5 mm was planned to be implanted directly with a high landing zone. The size of 24.5 millimeter was chosen because of the mildly calcified leaflets, but 2 cc were removed from the solution inside the balloon in order to have an oversize ranging between 8 to 10%, while with the 23 mm Octapro, we would have had an oversize less than 0%. Commissural alignment with the Octalign technique was also planned, and low contrast procedure was also our aim. So based on the specific CT of this patient, the mid segment of the right cusp was located at 2 and 57 hour, and this is the orientation of the crimping of our Myval Octapro with the crocodile compass device. This is the baseline aortograms. As you can see, there is this chunk of calcium protruding from the NC to the LVOT. So the goal was to land as higher as possible without reducing the contact with this anatomical structure. Landerquist wire was placed in position. Python 14 French expandable sheet was advanced through the right common femoral artery, and before to advance our Octapro 18 French dilator was used to expand more the sheet. Octapro was inserted from the right common femoral artery, and before to advance the device outside the sheet, it was checked the position of the valve over the balloon. It is very important to maintain the right position between the two stoppers, which are identified by the two RadioPEC markers you can see on the right side of this slide. So once the positioning is checked, then the valve was advanced. No flex was needed in this case. The shaft of the Navigator Pro is extremely flexible, as well as the Navigator inception, so it crossed the aortic arch of this patient quite easily. Then the Octapro reached the target. So before the deployment, it is very important to try to align the lower segment of the RadioPEC marker. You can see here with the bottom of the pictal when it is located in the bottom of the non-coronary cusp. Check with some contrast and then deployment. So as you can see, the valve during the deployment is very stable. The final landing was relatively high, no dislodgement, no major movements of the devices were noticed during the deployment. And this is the final aortogram in the tricusp and in the cusp overlap view. So as you can see, the valve was finally deployed almost at ground zero, limiting the contact with the LVOT calcification. In terms of hemodynamics, as you can see, the gradient was zero at the end of the procedure, and also the final echo images were very reassuring. No PVL and mean gradient of 5 millimeter of mercury. So the patient did not require any pacemaker, no rupture, no significant leakage, and he was discharged 3 days after the index procedure. Thank you very much for your attention.
Let's see if there is a question, maybe. No?
There was one question, and that is mathematical. If it foreshortens less, will you end up with a taller valve than before?
No. So what happens is, if you look at the upper row, it is a V. If it was projecting up, it will increase in length. Since this is made the chevron shape of V, when it expands, it doesn't increase in length. So though the length is slightly taller than the Octa core, but this doesn't actually foreshortens about 10%, which is not noticed. It is more on the lower side than the upper side. So overall, you will not see any reduction in the size.
I think it was a critical question of Andreas and a good answer from you. The panel, I mean, we have been listening quietly, but does the panel have some comments, some question? I have one question for you, Alfonso. The dilatation inside the python, when you have some difficulty to advance, do you have any idea of the frequency of that, and if there is a drawback of that technique?
Well, I do this kind of pre-dilatation every case. I perform with the Myval family, at least Octacore, and now with Octapro, in order to have less resistance during the advancement. So the thickness of the sheet is not so high, so I prefer to expand it and avoid the contact of the cobalt chromium of the crimped valve with the sheet and also with the vessel. So it is very much critical in intermediate sized peripheral access. In this case, there was probably no need, but because it was the first Octapro cases, I did it just to be sure and to avoid any kind of issue with this case.
I think it's a very important comment, because the new people working with this technology can be, you know, feeling some resistance and then saying, okay, I stop the procedure, I put another sheet, and so we have seen that. So the fact that you can dilate the python Though apparently I've never heard a story of a catastrophe after that. You can always think that there will be a catastrophe one day, but apparently it works. So it's a very important piece of information that you do that almost on a regular basis. Yeah, please.
I have a question. Great cases, both Alfonso and Dr. Singh. Alfonso, you subtracted 2 cc's from the nominal volume, so we need more intermediate sizes. It's just, as a 0.25 millimeters difference. I mean, this is a very, attentive calculation that you made.
Well, it is something like an anecdotal maneuver we are doing in many cases with balloon expandable devices. In this specific case, it was related because of the 12.5% theoretical oversize according to the valve and the annulus. So it was something like anecdotal and empirical maneuver, not related to a specific calculation based on the...
I was kind of joking because the company may come up with 0.25 millimeters in difference in sizes, but what you did was really a great case, because I would have been very anxious with this kind of anatomy, and you showed, as well as in the first case, that you can really precisely position and calculate it. I think you landed 1.5 millimeter below the level of the annulus, so avoiding the calcifications. Also in the first case, there was that big septal bulge, which would have been a problem with the self-expanding valve as well. So really, I do appreciate this fact that you can be so precise during inflation, and so you can predict exactly where you want to land.
And also lowering the amount of volume inside the balloon and reducing the oversize could be associated with a lower rate of permanent pacemaker. In this patient, the right bundle branch block at the baseline could have been associated with a higher risk of pacemaker. That's why we try to be as higher as possible and trying to lower the oversize as possible on the other end, facilitating the anchoring.
Great.
Alfonso, another question. Yes, my compliment, very complex case. Did you feel any difference in terms of trackability and crossability with Octapro in comparison with the previous valve?
Well, this is the first case I did personally, and I have to say that the feeling is that the profile of the device, it is lower as compared to Octagore, so it is advanced easily. So probably on this point, they did a very nice job in terms of reducing the profile of the device.
100% experience.
Simon, do one, each one.
Okay, so if there is no more question, you have a question.
I had a message with ultimative authority. Okay. Sanjeev says the Octapro is only 1 millimeter taller than the Octacore. That's the number.
Excellent. So we will move to the next real-world experience with Rajneesh. He's there, yeah. And the Python. No, that's the other. Yeah.
Thank you. Thank you very much for having me here. It's a real privilege. And before I really start, with the permission of the esteemed panel, I'd like to confess one thing. Over my 25 years of practice, I have always been thinking, when would a stage arrive once the world talks of Indian products? So I think standing here talking of an indigenously built Indian product, it's really a privilege and honor. So I'll just take you through another lifetime experience with this new valve, Octapro. This case I did a few weeks back, and now we have done few cases with this. And I think the cases which have been shown up till now, they were all usually tricuspid aortic stenosis. So India is full of bicuspid aortic stenosis, and my case talks about that. So that is a different experience altogether once we deal with TAVR and bicuspid aortic stenosis. So I have been a proctor for Merrill, and this is the patient data. So this is a 67-year-old male patient, had class 3 to class 4 symptoms, also had an episode of pre-syncope, had been a hypertensive and diabetic for many years. So now the diagnosis is, after echo and the various investigations, that patient is having a severe calcific bileaflet bicuspid aortic stenosis with normal LV function. Mild MR, the normal pulmonary pressures, some RV dysfunction is there, and moderate concentric LVH. So surgically, he's a high intermediate risk, and this is the transthoracic data. The mean gradients is 80 millimeter of mercury with aortic valve area of 0.3. So as I mentioned, the LV functions are normal. So this is a 3-Mencio analysis. Look at the perimeter of 80.4 and area of 495.4 with the area derived diameter of 25.1. So now I think previous speaker also mentioned some extension of the calcium into the LVOT. So is the case. So is the thing with my case also. Coronary heights were fine. It was a moderate calcified bicuspid valve, which I'm going to show in the next slide. Look at the sinus of valsalvas are relatively okay, but there is a big chunk of calcium nodule in the annulus extending into the LVOT. So this is the pictorials on the CT. It is a bicuspid valve, as I mentioned. Angle is not bad, moderately calcified, and main issue, slight issue, is the chunk of calcium extension into the LVOT. So because of that, I was pretty comfortable with 26 millimeter valve, which is 7.2% oversize, with Octapro. So this is the analysis, the synopsis, the bicuspid type 1A aortic valve, moderate aortic valve calcification, annular calcification observed, calcium extending into the LVOT from left coronary cusp and the non-coronary cusp. Narrowed, little bit narrowed left sinus of valsalva diameter, although I think it was pretty roomy, and a borderline left coronary height. So this is the various dimensions as to how we take the sizing of the aortic valve. So whenever we have a tapered or a funneled anatomy, we do take the ICD, the intercommissural distance, at 4 millimeter, 6 millimeter. But this is how we really decide that do we really go with the annular size. So first two, the tube and the flare, I think we go by the annular size. We don't go by the ICD. But yes, if it is a tapered topwards, then the ICD is more important. So in this case, it was annular size. And as I mentioned, the 26 millimeter was the choice here with Octapro, which is around 8% oversize. So these are the key remarks which I have already talked about. And this is the valve which I think has been shown by all previous speakers. It is, I think Sanjeev mentioned one, but I studied it's a 2 millimeter extra height with Octapro as compared to Octacore. So with 10%, shortening, it almost comes to the same. So ultimate height remains the same. But one thing which I think has not been discussed. So with the cells on the outflow, now this is a decagon, and the cell height has been increased. Plus this chevron on the outflow will ease out the coronary reaccess. So probably this is also a boon with this valve, that if we have to reaccess the coronaries, it becomes easier with this valve as compared to the previous product of this Merrill. So this is my case echo, and look at, it's a very severe critical aortic stenosis, calcified bicuspid valve. These are all the echo findings. And this is the procedure. There is a pigtail in the non-coronary cusp. And look, it clearly discerns that the calcium is extending into the LVOT. And pre-dilatation done with a 20 millimeter balloon, mammoth balloon. And there is some kinking there still. It was quite a calcified valve. And this is the positioning now comes there. So as I concur with Dr. Seth here, that with our previous practice, we tend to be a little deep because we still are not tuned to the idea that it's not going to foreshorten at all. So look at this. This is very important picture, and it tells that hardly any foreshortening is happening. So if we keep the markers there, so hardly any foreshortening is happening. And this is the, I think, asset towards this valve, and this is the final picture. So this patient did well. So almost very shallow deployment, preserved coronary arteries, commissural alignment was there, no PVL. And most of the last few cases we have done, we usually are using now a Manta device. This is a Manta device at the femoral closure. So patient did quite well, and these are the post-procedural echoes. So look, there is an absolute laminar flow at the aortic valve, no PVL. And this is the summary now. The final gradient, mean gradients were also 3 millimeter of mercury. So literally we're talking of a reduced frame foreshortening, almost 10% or lesser, very controlled valve deployment, and preserved access to coronaries, to the future PCI is another asset, I think, which we may like to see with times to come. So leaks are not there. This patient didn't require any pacer or anything. So patient successfully was discharged on the third day itself and is under a follow-up. This is one more slide. I think this is Indian data. I like to put emphasis on this. This is very, very important slide. Now, this is the first 30 patient data of Octapro usage in India. So now the PPM has been calculated here in all these 30 patients. So out of this first 30 patients, there is no PPM in 37% of patients. And these patients had a smaller annulus. So we are talking of an annulus less than 430, no PPM observed, post-valve deployment. And a mild PPM where the indexed effective orifice area is more than 0.85. So rest of the patient had mild. So this is the moderate, and the red bar is the severe PPM. There is no patient in this zone. So I think this is very important that we have doing this practice now, calculating the PPMs in all patients post-valve deployment. And this initial data is looking very encouraging as we talk about a PPM after the deployment of Octapro in Indian subsets. This is a very initial data. Thank you very much.
So one question has been discussed a few times now. When you have a bicuspid valve and the two coronary arteries are coming from the same cusp, how do you do the alignment?
So yes, that is a very tricky question. And obviously, we only have two cusps. So the commissural alignment then is very, very tricky, and there is no data where it states that how actually to do with that. And you are mentioning there is a right-left fusion. So right and left arteries both coming from the same cusp. So practically, I don't have an answer to this, and we require more analysis of this as to how do we do the commissural alignment.
No, actually, it's very easy to align when you have both in the one because you just have to align one artery. So instead of commissural alignment, it's coronary alignment. So you just have to align or just on the coronary in the CT, which just goes opposite when you introduce. So it's much easier to protect just a single coronary artery.
And an advantage could be use the cusp overlap view, especially in this kind of bicuspid anatomy, because you have the raphe totally in other side, and you can calculate very well the position of the valve and the height, because the raphe is in the other side. So this is another trick.
So practically that means we don't require a commissural alignment in this case.
Yes, exactly.
That's a simple solution.
Exactly.
I have heard that from some of your colleagues that they look at the dominance of the vessel. They don't want to have, if it is not dominant right, they have a tendency to go on the left. That's not the piece of equipment. But your answer is very practical. Thank you very much. Any questions?
Yeah, there was one to that effect. Can you elaborate more and describe step by step the Octalign technique? Probably not the time. Any CT data supporting the effectiveness? That's probably a question for the panel. The question is, can you describe step by step Octalign technique? Not sure we have the time, but maybe the essential steps and any CT data to support that. And that's the real...
CT based only. We have to have a right coronary artery origin, and that origin is practically tested that on a clock, at what clock parameter the RCA is getting originated. And once the valve is getting crimped, it is crimped in such a situation that based on that RC origin only, that once the crimping is done according to that clock parameter, and once it takes a turn, it comes on the other side. So basically, CT is a very key investigation for the Octalign technique, mainly to see the RC origin.
Very good. Thank you. So I think that the multi-slide CT scan post-procedure is something which is increasing all the time. It was basically introduced in the TAVI many years ago with the surgeon Rüdiger Lang, and since then it's really a must. Yeah. So the last talk is extraordinary TAVI using Myval Octapro and Python BZ Smart Introducer. That sounds ominous, BZ. Yeah?
Firstly, sincere thanks to Merrill and PCR London for this opportunity. And second, obviously that topic and heading was not mine. It is from Merrill. So with that, I'll show the case. Here we are going to demonstrate two of the important innovations from Merrill. One is the Octapro, which we have been talking the whole session. And the second one is something called the Python BZ sheath. I'll just introduce that, and I'll show you the first-in-man case for that. This has been well covered, so I'll skip that. This valve is unique. The foreshortening is very less. And these are the heights of the valves. Obviously, as alluded by Sanjeev, it's 1 millimeter taller than the other one, but obviously when it foreshortens, it's more or less the same. The marker is the new introduction to this, very important, the depth marker, and this is where it's something I think we need to get used to, especially if you've been an Edwards operator. This marker is very crucial. Keep the depth marker at the bottom of the pigtail. Forget about the rest of the things. Your valve will take in a good position. This has already been discussed by Dr. Rajneesh, so I'll skip that. So what is this case? 83-year-old, admitted with heart failure, absolutely fine prior to that, diabetic hypertensive, previous TA and COPD, but very active gentleman. Echo, severe aortic stenosis with severe LV dysfunction and moderate pulmonary hypertension, moderate coronary artery disease. And that is the CT scan. Watch the left side panel first. We call it the scroll up and down technique. Whichever TAVI operator you are, you need to get used to assessing the CT by yourself. Is very crucial, apart from the companies helping you. So this is a very heavily calcified valve. It's a type 0. This is exactly what Professor was asking. 2 coronaries coming from the superior cusp. And the right-hand side shows the heavily tortuous aorta, about 4 different bends. These are the parameters. Area derived 23. Now, if you size it with a 24.5 for this, it comes about 10 to 11%. Never do that. This patient, I prefer to use a 23, which is a minus 2% oversize. And that's very crucial when you're using a balloon expandable valve. So because of the amount of calcium there, I want to highlight it is bicuspid, type 0, horizontal, heavily tortuous aorta. The calcium score is almost 2,400, 2,600, very heavy calcium score. Only good thing for this patient is fantastic femorals, 8 to 9 millimeters, almost 10 millimeters. Let us see how it works. A simple sort of wire, you see how it behaves. This is what we call the palpation technique. When you do the coronaries, when you put the coronary wire, it tells you something, nitty-gritty of the calcium inside the coronary. Same thing with this. You just take your normal wire and see and how you feel. It's very important. And then the next step, through the pigtail, I'm trying to put in the normal sort of Teflon wire. See how difficult it is to get through that. Now this shows the calcium. So I have got in the contralateral pigtail, a Landerquist wire, which is the common sort of technique. You use a Landerquist in the contralateral pigtail, and then use the stiff wire in your work. Now that's how it looks. And the right side picture, I want you to see the right side picture. I have got a Landerquist in LV. I have got 2 Landerquist in the contralateral, upsizing to 8 sheath. Even with that, this balloon was not going through that. If the balloon was not going through that, you are in trouble. So what do we have? Alternative options. Alternative access, carotids, we had previous TIA. I have got the vascular surgeon in room. He's prepared to open and give either a carotid or axillary. And my sort of Merrill colleague said, sir, we have a new sheath, we'll try it. I said, okay, because to be honest, I wasn't aware of this sheath and also its characteristics. So I'll introduce the sheath now. This is called Python BZ because two of the senior professors have worked on that. Professor THV from India and Ziad Ajes from USA. That's why it's called Python BZ. It is 24 French. It's a 76.5 length. But the most important characteristics is this. It's got a triple port where you can thread in 3 stiff wires, which will help you to straighten out most of the tortuosities. And it's got a fantastic locking mechanism in the behind. Even with 3 stiff wires, you will not have any back bleeding. So that is how it looks, and that's the front end of the sheath. So to test it, I wanted to see. First, I put 1 Landerquist. The sheath was not going. I put 2 Landerquist through that. It's still struggling. This is with 3 Landerquist. See the amount of tension I have to put in to make it bend over 3 Landerquist. There we are. Then we are done. So now the other important characteristics of this sheath is, given the amount of tortuosity, it keeps a nice straight, and because of the braided nature, it doesn't kink. So that's beautiful. So 80% of the case is done. Now I'm crossing. It's very unusual crossing. I do it in RA nowadays. And you see, my assistant was saying, sir, you are through the cusp. I said, no, I'm not through the cusp. See how the wire is going? This is the false kind of orifice impression. That is a heavy calcium in your other cusp. But it's OK. I have crossed. But never accept this position on the right side, because you will never get a valve in. You have to get it to drop into the commissure. That's what I'm trying to do, manipulating. And the end, I've made it drop into the commissure. That's very important. Without that position, you will not get the valve in. Now we are down, nice in the apex. So got the wire down. The sheath is up to the ascending aorta. If you have seen the morning AR case, this is how that long sheath looks like. But this is in a very tortuous anatomy. And that's the balloon. Pre-dilatation is mandatory because of the heavy calcium. So it's just enough to make the facilitate. It's about 16, I think 16 or 18, I cannot remember. Now the valve, it goes in the bend, it gets stuck. Up to that, it's not going. So I wanted to switch over to the other view and see what's happening. See that? So now we have to use the flexion. Again, more flexion, extensive flexion, and then still difficult. Yes, we are there. Now, after all that difficulty, this Octapro, the new valve, I'll show you in the next picture how beautifully it deploys. Bottom of the pigtail, the marker is there. And watch the top. It will not be any foreshortening. Watch the bottom. It's 10% foreshortening. So there's no foreshortening there. There's 10% foreshortening there. And a beautiful kind of no AR there. You remove that large sheath over the 2 Landerquists. Don't try to pull it in a hurry, because you will injure the neck vessels. And 2 ProGlide and 1 Angiosul, absolute hemostasis. And that's how the valve looks. Almost 0%, no foreshortening, amount of calcium, minus 2% oversize. So this is the beauty of these 2 products. Octapro, it's there. It's the best of the valves in terms of the foreshortening and other things. There are 2 randomized control trials. I think more and more evidence will come through. And Python BZ is an additional armamentarium which can be done for this kind of very high-risk anatomies with excellent result. Thank you.
Very good.
That's good.
I think the title of your talk is not exaggerated. It is an extraordinary case. I mean, with all the complex things that you could put together. No, it's brilliant. Any question from the audience?
Yes, there's just a need for clarification. The new sheath is 24 French. It asks why 24 French. Can we use it also for other devices?
Yes, so it comes in multiple sizes, 18, 20, 22, 24 available. For this one, to take in the valve, 20 mm or 23 mm Octapro, you need a 24. But there are other sizes available. We mainly use this long sheath in the right heart. When you want to deliver a pulmonary valve in a RVOT dilated, all those situations, it's an excellent sheath to take it over stiff wires.
Wonderful.
Is it one balloon for all sizes? That's probably...
One, sorry?
Balloon for all sizes is one of the questions.
Yes, I think for balloon expandable valve, I'll tend to use just a 16R rating because you are facilitating, you are not modifying. It's just your like a rotablation practice. Nowadays, we've gone to a 1.5 burst size just to modify the lesion. That's exactly what we do with the balloon expandable. Just one balloon just to facilitate the balloon.
Very good. So just the conclusion is quite simple, Andreas. I mean, we got the feeling of a great simplicity and confidence in something which is very manageable. Yeah, that's point number one. The second point is a little bit philosophical, is that the geomedicine of the geopolitics has changed. I mean, 25 years ago, we used to go to India to teach. Now I will go to India to learn. And if I see the panel, it's quite amazing to see all our brilliant colleagues from India tell us how to do it. The other point is that I'm being impressed by the ingenuity and the engineering of that company, Mary Life, who solve a lot of problems month after month. I mean, there is a great decision-making, listening to the clinician, and then keep improving. So I think the sky is the limit and the future is bright. And I think for the people who are not yet in the field or not yet have not yet used that technology, they will be surprised by the simplicity, but you will have to interrogate your colleague from India when there is a complex case. That's my conclusion. Thank you very much.
Excellent.